Hello, good morning. My name is Marco Flamini from Bio-Rad Laboratories. Welcome to this Bio-Rad Satellite Symposium organized at the International Conference of the Thalassemia International Federation in Malaysia. I'm very honored to introduce Professor Carmencita Padilla, Professor of Pediatrics at the University of the Philippines, a leading scientist in newborn screening, a great experience in newborn screening, and she is part of the International Society of Newborn Screening. Today, in this meeting, we will try to review different visions and strategies in screening for hemoglobinopathies before birth and after birth. Let's start. Linked carrier and newborn screening at the dawn of gene therapy. Okay, what we are going to talk about today, about the differences between screening before and after birth for hemoglobinopathies, how HPLC expanded the panel, introducing a broader level of information, which are the geographical differences in epidemiology of hemoglobinopathies, some key studies in newborn screening on alpha and beta thalassemia, how it would be important a collection of data to set up cutoff values, and then one last slide about gene therapy. And I'm going to ask, is gene therapy bringing changes in laboratory screening? Here are the two perspectives in hemoglobinopathy screening. If we talk about carrier detection, we are talking about the couple and primarily screening for thalassemia, beta thalassemia particularly, and the experience in the Mediterranean countries. If we talk about newborn screening, then it's disease detection, and primarily it is sickle cell, and then something about thalassemia. So my question is that both strategies are obviously targeted to improve lives of people living with sickle cell and thalassemia. And let's see if it's possible to mix the two things, the two strategies. Screening adults for carrier detection, which are the pros. Reduce new affected births. There are data, clear data about the success in the Mediterranean countries. It is focused on beta thalassemia. Genetic counseling increases genetic awareness on reproductive choices. Studies are showing that the cost of prevention is much lower than the cost of management of the disease. And other hemoglobin diseases are also found in the screening of the adults. Which are the cons? Organizing screening campaigns is not easy. There are cultural and religious constraints. Alpha thalassemia, it is not easy to be detected in the adults, the carriers. Mandatory pre-marital test may cause rejection of patterns and stigmatization. And then the availability of DNA testing for confirmation, it can be an issue. Many adult carrier screening programs have been organized during the years in many countries, in the Mediterranean countries, in the Middle East, in India, in the Southeast Asia, Thailand as a leading country, in China. And all these experiences brought a reduction of new thalassemia cases during the years. And these were successful stories. And we at Bio-Rad are proud to participate to these success stories. For many years, we contributed with our technology to the automation of screening for hemoglobinopathies. What is the perspective in screening newborns? We are talking about disease detection. So the pros of this strategy is morbidity prevention. That's the first objective on newborn screening. Newborn screening existing framework facilitates a high coverage, higher than 90% worldwide. The advantage of newborn screening is that alpha thalassemia can be detected better than in the adult carriers. You can generate awareness because the families are informed, and other hemoglobin diseases may also be found. And what are the cons? It's not easy to identify beta thalassemia carriers. Genetic prevention or counseling only for subsequent pregnancies. Here is a recent map from the International Society Newborn Screening about the current state of neonatal screening around the world. As you can see, in many countries, the level of coverage, it is up to 100%, with some regions are screening up to 40 different diseases. And this is incredible. Some other regions of the world with the light blue are trying to improve their number of diseases to be screened, and probably also the level of coverage. And here in green is the pilot studies that are organized to have new projects for newborn screening and new coverage for newborn screening. Here is our variant NBS, fully automated, reliable system. It has been developed in a newborn screening laboratories with millions and millions of tests run in California. We developed the software of this system. And it's the system, is the technology that was able to bring and to expand the panel from homozygote only detection to compounds, to traits, and to beta and alpha thalassemia. This is an interesting slide from California showing which are the disorders identified in California state in the newborn screening. So 59% of sickle cell disease, 33% hemoglobin H, and 8% of beta thal. And you see about the ethnic groups that are represented in California based on the different disorders. So sickle cell disease, primarily Black and Hispanic, hemoglobin H, Southeast Asia, Filipino, Chinese, and others, and beta thalassemia, Southeast Asia, Black and Asian Indian as well. Here, two tables that I have taken from a publication of APHL, American Public Health Laboratories, showing the top 20 hemoglobinopathies, both heterozygote and homozygote, in two states of the United States. And as you can see, it is not only sickle cell disease, it is S trait, the first one, and then Bart's and alpha thalassemia, hemoglobin H, S and beta thalassemia. So newborn screening laboratories in the United States are reporting alpha thalassemia, reporting compounds of the hemoglobin variant and beta thalassemia major, and also traits. This is an example of the information that one of the United States newborn screening laboratory is distributing to the families and to the healthcare provider to inform them about traits, about compounds, about genetic risks for the next pregnancies eventually. Let's review some of the studies that have been done on our HPLC during the recent years. Okay, this one from Professor John Old in the UK about hemoglobin Barts in cord blood as an accurate indicator of alpha thalassemia. This one was an interesting paper on hemoglobinopathy in newborns in Oman, so in the Arabic Peninsula, and it was with the Omani group and the French group, and they were studying the level of hemoglobin BARTs and also the level of hemoglobin A in order to predict eventually beta thalassemia. This one is an interesting paper that was detecting hemoglobin variants by HPLC at the National Cord Blood Unit in New York City. Thousands and thousands of samples have been screened on HPLC, and the conclusion is that screening with HPLC, when used in combination with CBC and a family history, it can be a useful tool to identify possible alpha and beta thalassemia carrier in cord blood units. And this is a very interesting paper. This paper was one of the first who started to study the level of BARTs and correlate the level of BARTs with the genotype. Was done by the Dutch group with the help also of Professor Garanello at that time. And you see that there is a relationship, a clear relationship between the genotype, between the genotype and the median level of fast peak on HPLC. Not many samples, and the only limitation is that the first group with 6.2, in the end, it was not screened for point mutations. Only deletions were screened in the negative sample. The possibility of identifying alpha zero carriers is very important for the newborns. And probably the specificity has to be improved, but data are really promising. And the interest in this publication that was edited by the Thalassemia International Federation is that reporting alpha thalassemia carriers potentially provides early diagnosis to a large category of carriers who otherwise may be at risk of drawn out, mistaken, and expensive attempts at diagnosis and likely unnecessary treatment with iron. Okay, so it will clearly help a pediatrician to manage kids that have been already identified as at risk of being an alpha thalassemia carrier. These two papers from the UK teams are targeting beta thalassemia. Beta thalassemia, the possibility to detect beta thalassemia major in a newborn, looking at the percent of hemoglobin A, and with the integration of the GA, the gestational age. And as you can see from the graph, they studied millions of babies, and they define as cutoff 1.5% of hemoglobin A. Anything which is lower is screened as positive for beta thalassemia major. Then it will be confirmed, obviously. And the test performance of the studies they did, it's really interesting. Specificity 99.9%, sensitivity 98.5%. So also beta thalassemia can be detected at the newborn stage. This is a key interesting article, paper from Professor Jacques Elion in France, and they studied the different percentile values of hemoglobin A as a function of the gestational age. So being so accurate is then possible to improve the specificity for beta thalassemia, for instance, as well as on the other table 3, the ratio between the different fractions when there is hemoglobin, any variant, the ratio between the hemoglobin A and the variant can help to differentiate, for instance, between beta variants and alpha variants. These are the impressive data in Southeast Asia about beta thalassemia, about alpha thalassemia, the interaction of the two, and hemoglobin E. So I don't have to tell you more than what has been published by the WHO organization. And so, looking at the near future, with the ability that we have to collect millions of data of screening newborns, with the help of statisticians, I'm expecting that we are going to improve specificity, for instance, on the median values of hemoglobin A in the normals integrated with the gestational age. We will better differentiate the cases with mild beta thalassemia mutations, confirm the value of cutoff for BARTs, for hemoglobin H, for alpha 0, and for alpha plus, and then better differentiate FEA patterns, that is E beta plus, or FE, which is beta 0, and EE, and again, the ratio of the percent A versus the hemoglobin variants to differentiate alpha and beta variants. And I'm sure that with the technology, with the statisticians and data mining, we will improve the level of information that we can provide. These are some of the patterns that should be of interest, especially in Southeast Asia. So it's not only sickle cell disease and not only alpha thalassemia, but pattern like F only beta zero thalassemia, FA with very low hemoglobin A beta plus thalassemia, FEA, which is E beta plus thalassemia, FE, which is E beta zero or EE, and then BARTs higher than 25%, it's hemoglobin H disease. About gene therapy, which is a reality today. But Bio-Rad is doing its part in terms of providing technology to research centers that are involved in gene therapy with our HPLC to monitor the inducted increased amount of hemoglobin F. But most importantly, I would like to raise a question about gene therapy and the perspective that we may see in screening for hemoglobinopathies. I don't know if we may think to a future where uh, we are going to screen newborns, identify those with a genetic defect, and intervene immediately with gene therapy to solve the genetic defect. I hope that this is something that we will see soon as a reality. And with this, I have finished my slides, and I thank you all.